Dean Jessica Berg. I am the Dean of the Law School, and more importantly, I am a health law faculty member. Our Law Medicine Center, as you may know, is an extraordinary group of people and does some really phenomenal work. This is our annual conference. The Law Medicine Center is run by co-directors, Professor Serona Hoffman and Professor Max Melman. Professor Hoffman was actually the key coordinator of this conference. This is an area she writes in regularly. This is a great conference. I think you've got a phenomenal group of people that will be speaking. As I understand it, some of you who are not as good as getting up on time are going to filter in as the day progresses. But I wanted to note a couple things. One is that we were lucky enough to be co-sponsored this year by the Case Western Reserve University School of Medicine. And we also received support from trustworthy EHRs, both of which we really appreciate in helping us put this on. You have a phenomenal group of people. I'm really going to turn it over at this point to Dr. Hoffman and let her go ahead and tell you what's going on for the day. But thank you all for coming today, and enjoy the conference.
So, good morning. We're delighted to have you here, and we are so grateful to our speakers. I think this will be an enormously enriching conference, and I'm very excited about it. So I want to thank my co-organizers. We couldn't have done it without them. This was really their brainchild, Reed Gelzer and Chad Brouillard. And I also want to thank our phenomenal administrator, who was enormously helpful, Patty Kim Harbold. She's the person, right? I think she's outside doing administrative things as we speak. Please see me or her or anyone from Case Western if you have any questions during the day. So I think we are going to get started. We have, you should have a sheet in your folder, which hopefully you got outside, which tells you the complete schedule. We have panels for about an hour. We have lots of breaks and a lunch, and the panels will have about 20-minute presentations, and then we're aiming to leave about 20 minutes for questions and conversation at the end of each hour-long session. So we are going to begin with electronic health records and emerging technologies, attributes, benefits, and shortcomings. We have with us for this panel Dr. Dean Sittig, who is a professor at the Center for Healthcare Quality and Safety at the School of Biomedical Informatics of the University of Texas Health Sciences Center in Houston. And along with him, we have Professor Nick Terry, who is the Hall Render Professor of Law and Executive Director of the Center for Law and Health at Indiana University, Indianapolis. So, please.
Thanks so much. It's great to be here today. We were both commenting on the name of Dr. Gelzer's company, Trustworthy EHRs, and thought that was a bit ironic. So,
maybe an oxymoron.
Yes, that's what I was thinking too. So the way I'm going to try to organize my talk today is tell you a little bit about sort of how an EHR works, and then try to talk about some of the things that can make it a little less trustworthy than you might think. Seems like it's too loud. You guys feel okay? Can you hear me okay? Yes. So just to start with, the hardest part of an electronic health record is trying to understand that it's a lot more than you see. And so when people see an EHR, they see a little computer on their desk and a little screen, and they think that's the EHR. And there's, as with most computers, there's a huge infrastructure behind that. And so we're talking about several million lines of source code, where each line says, like, if X is greater than 5, do something. And then that's one line, and there's millions and millions of lines like that have been developed over many, many years by many, many different people, which makes this a difficult thing to manage. And then there's data from lots of different sources. So like in a hospital, you have data from all over the hospital, which may be in a central database and may not be in the central database. And so when you look at an electronic health record, this is what you see. And so you can see it's confusing. You're not supposed to be able to read all that. That's a HIPAA violation. No. I'm sorry. And so what you're thinking about is, there's things like reminders for the doctors of what they're supposed to do. And so you can imagine if you're a lawyer in a case and your doctor forgot to do something, and a plaintiff would put up something like this and say, well, doctor, the second line there said you were supposed to do this. What were you thinking? But you can see there's a lot of stuff on there. There's the patient's problems. There's some more alerts. There's some medications. There's some notes in the allergies. There's a lot of things here. And each of those things they can click on and then read a whole other thing. And then sometimes when you get to that, you can click on some more stuff. And you can go down these rabbit holes. And I don't know if anyone's been to the physician. You all look like you're old enough to have been to the doctor recently. So, but you have about, or you should. Not trying to sell anything. But you have about 15 minutes with your doctor. Your doctor might have spent, if she was good, spent maybe 1 or 2 minutes looking at this record just to remember who you are. So when you walk into the room, you can say, hi, Mrs. Hoffman, something like that. But he doesn't remember. They don't remember what's going on. They're looking at this, and they have 2 minutes to try to look through all that stuff. That's tough. So behind the scenes, we have this large central database. On an ambulatory record, this is in the physician's office, but these are also on the cloud, these databases. And the cloud just means someone else's computer, somewhere else it's connected over the internet. So we have this integrated database. We also have stuff from the pharmacy, which is a separate computer system, a separate organization. If you're in an outpatient clinic, this is your CVS or your SureScripts or something like that. We have stuff from the laboratory. We have stuff from the X-ray department or radiology. We have devices that are connected to this computer system. And then we have these alerts and reminders. And all of these things can be used to try to understand what happened to the patient. So you have to understand where all these things are, what they're doing, and all these places that you can look for something. So it's really just a huge, huge undertaking to build one of these things and to use one of these things. And it's very easy to get caught up in thinking it's that little computer on your desk, because they carry it around, but that's really just the little front end. It's like you're carrying the whole internet when you carry your computer with you now. So the good things, I'm trying to be more positive. That's been my New Year's resolution for the last 3 years, and it's not doing so well. I think of myself as a practical realist. Most people see me as a pessimist. So I was supposed to talk about some benefits. The benefits of these systems are immense. I mean, we've spent millions or billions of dollars building these things. It's changed healthcare. It's made it safer and better. They're really, really good. I'm just, I thought they were going to be better, and I thought it was going to be better is the problem. So, the data is all legible now, so we're not ever going to argue about reading something. We hardly ever lose it anymore, like we used to lose paper charts all the time. It's almost always available in different places. We can record who looked at it. And we have what we call metadata, and that's the data about the data. So when you type something in, we know who you were that typed it and what time you typed it. In the old days when you wrote something on a piece of paper, I could write something and said, this was Sharona Hoffman, and sign it. And it was hard. And I could say, I wrote it yesterday. And a good lawyer would say, well, I see Sharona's handwriting looks like this, and I see this handwriting looks like that. It doesn't quite look the same. We get a handwriting expert. We might be able to argue that she didn't write that, and maybe you could say something like that pen's different or something like that. So that's the kind of arguments we used to have. Now we have these arguments about, it looks like Dean was signed on to the computer at this time, and it looks like he put it in. So now I argue that I must have walked away from my computer and someone else must have done it because I didn't do that. So we've still got arguments, and we're still doing that. And so we have these shortcomings of when you do your case, usually you're seeing a paper copy of the electronic record. And the paper copy is not the same thing as the electronic record. And it's way different. I'm going to talk a lot about that. The other thing that's missing is what I call the why. So we know what they did and when they did it, but we don't know why they did what they were doing. And that's what you really want to do. That's that intent. And that's really hard to judge from this record. And then we have these audit logs, and you'd think the audit log would be great. And that'd be the beauty part of it. You know, when we see these planes crash, we look at that black box recorder. It records everything that happened for the last 30 minutes before the crash, and we can find out what happened. We see all the instrument rate, what happened on the instruments, and we don't have that in the EHR. We just have who looked at what record at what time from what computer, and we don't know what they looked at on the screen. We just know they looked at a screen. So it's not a complete black box recorder, so we can't recreate everything that happened in the record. That is painful because you want to know everything that happened. So when we're talking about electronic health records, there's lots of ways they can fail. And these are 5 of them, my favorite 5. And the first one is like just the hardware and software just fails. And so this is when you open up your iPhone in the morning and you try to turn it on, the battery's dead, or you have got water on your screen underneath your thing and it won't work. It just doesn't work. And then the clinician has to do something to get around his data. So they've lost their data, lost the record, things like that. This is not the most common way. Like, this is the worst thing that can happen, but it's not the most common. These things are, I mean, your computers are pretty reliable. We usually talk around somewhere between 95 and 99% reliability. That's better than most of us are. There's also problems when the system's just been poorly designed, and so you can't really use it the way you want to, and that's what we call usability problems. You make your mistakes. That's when you hit reply all instead of reply on your message. You know, you weren't trying to do that. You just made a mistake. It was so close together. It's very easy to do. We've all done it. So we make mistakes like that. So we also make mistakes when we just use the system incorrectly, and that's where we have a problem list where you're supposed to write down the patient has congestive heart failure and asthma and obesity, and instead you write down their phone number and the kids' names, because that's the easiest place to see it, and then you'll know there's their phone number, but it's not a problem at all, and then that causes other problems in the record when you have those kind of things in the system. So they're using it incorrectly, and we used to talk about those as workarounds, and I bet Ross will mention that, Ross Capel, later today. And that is I don't know if it's 20% or 50% of the way they work, but huge number of workarounds. So they're not using the computer the way they're supposed to, and that's like you're not supposed to use a knife to unscrew a screw either, but people do it all the time, and that's how you break your knife blade. If you have a little knife, you break it. Then there's these interface issues, and there's 2 kinds of an interface. There's the user interface, but there's also the interfaces between this computer and all these other computers that I talked about, like the pharmacy and the lab and the radiology. Those computers go through, one computer connects to another computer, and in the middle there's usually some sort of a translation device, and if that translation device is not correct, what you send from here and what you get from here are not right. And there's been cases where people were ordering smoking cessation medicine, and during the translation it got translated into Viagra, and they went to the pharmacy and they picked up Viagra. So both systems were working perfectly. The doctor's system, they ordered the smoking cessation medication, the Wellbutrin. It went through the interface, got screwed up. This system got the message and displayed the message, and the pharmacy did everything right. So everything worked correctly except that interface. That's a difficult error to try to pick out. And then the last kind of system is when either it's not turned on or it wasn't available. And so this is when you start arguing about what's the standard of practice. Like, should there have been an alert that said you shouldn't take these 2 medications together because they could interact? And we're always arguing about, is that the normal case or not? And that's in the legal, there's a lot of legal precedents for trying to argue when you should have, everyone should be using some. It turns out we turn a lot of our features in our EHRs off because they're difficult to use, they take more time, they bother people, there's 1,000 reasons why they turn them off. And I said I was a practical realist, but I'm also a little bit cynical, and some reasons they use that, they turn them off is because it changes the liability from the hospital if the alert was on. If the doctor did something wrong, the hospital can be blamed, but if you have an alert that says the doctor shouldn't do that, the doctor made the decision to do it, and so we can only sue, the hospital did their job. And so it seems like they're pushing the liability down to the person that's has the least money. We usually get it all the way down to the nurse if we can. And so we put most of our work on the nurses, the pharmacists, our lowest paid people, and we make them do things that they don't want to do and override these alerts, cause the problems, and then we get off the hook from the hospital level. When I think about an electronic record, I don't want to just think about these technical aspects because that computer is a very small part of what can happen in your system and what can go wrong. And so I always think about sort of the interactions between the people, the processes, the technology, and sort of the environment in which they're built. And by looking at all of those things, you can sort of understand what's really going on. And so all of these components have to work together to improve safety. And I talk a lot about shared responsibility. The organization, the healthcare providers have some responsibility. EHR vendors have some responsibility to both build the system safely and use them safely. And so, for example, you may have a Volvo because that's the safest car, but if you're texting while you're drunk on a night when it's raining and it's icy outside, your car is not much safer than any other car. So you've got to use it correctly. Or if you back up and just count on that camera and don't turn your head to look where you're going, that's not a good way to back up. And we're starting to do that more and more. So there's a lot of these interacting features, and it's really hard to identify where these errors occurred. And you need to sort of understand the strengths and the weaknesses and the pluses and the minuses and the truthfulness of each of the different components in this system. So when I think of this sociotechnical model, it has 8 dimensions. So I talked about the hardware and software, and this is the things that the mechanical, electrical devices that can break. We also have what I call the content, and this is sort of the knowledge that goes into these computer systems. So we have alerts and reminders, we have charting, we have the rules that make the displays on the screen. So how your lab graph is going to look is determined by the content. So you have to see about whether there's problems with that. Then we have this user interface. It can be difficult to use, difficult to see. The fonts are too small. It can be off the screen. There's all kinds of things that can go wrong there. And then we start to get into more social aspects, and you know the problems with people. They're just, they're unreliable. They're difficult to train. As a teacher, I'm sure you know that. We have human problems, biases. There's so many things that we do that are not ideal. And when we interact with the computer is black and white, yes and no, no gray area, and people are, just gray. But that's all. I mean, that's all we are. Is we are just. There's no right and wrong. It's so difficult, and so you're meshing something that's two things that are just the opposites, and that's always a problem. You're talking about oil and water almost. And then we're trying to use these to conduct a workflow where we're trying to get people to collaborate in your organization. And healthcare is a team sport. I mean, if you've been to one doctor, you've been to 2 doctors, and then a lab, and pharmacy, radiology, you go to a lot of different doctors. You'd think they would communicate, and since Rachel's here, I'll say we're doing our best to help them get to communicate. We've made rules, we've made standards, we've done our best, and we're not doing a very good job. We're not communicating much of our information. That's across organizations and sometimes even within organizations. Then we have our rules, our internal rules and regulations. This is like how the organization is supposed to run, and the computer system is the best tool we've ever come up with to make an organization run the way the rules and regulations of the organization say it's supposed to run. So if you're not supposed to spend more than $50, it's easy for the computer to say that receipt for $53 is greater than $50, put up a flag, and you can tell someone that they spent too much money. And we've taken doctors who are the most autonomous people that there ever were. They go into a room all by themselves with a patient. You take off your clothes. They see everything. They touch everything. And they could do anything they want, anytime, to any person. And then all of a sudden now we've made them an employee just like everyone else, where you've got a boss and people are looking at you and they're measuring you. And you can imagine how the doctors feel about that. And so they are upset about that. So these organizational policies and procedures. And then we've also got external rules, and that's what I mentioned, HIPAA. We've got the information blocking rule. We've got insurance company rules. We've got measurements. We've got thousands of rules from the external part outside of your organization forcing these doctors to do things, and that's why they're so mad. They blame it on the computer, but I think that's blaming it on the messenger. The computer is enforcing these rules, but our lovely government is making these rules. I hate to blame everything on Rachel, but she's the only one here I see from the government. So we have a lot of rules and regulations. That's why you have to log on to your computer and put in passwords. When I started, we didn't have passwords on our computer. We didn't have logins. You could come up to any computer in the hospital and just start typing in. So when I worked in Utah and I wanted to give a demonstration, I'd go into the ICU with my friend and I'd just type Smith into the computer because everyone in Utah is named Smith or related to Smith. And it'd give you this long list of Smiths. And I'd pick one of the Smiths that's in the ICU and I'd say, here's how the lab results look. Here's what that's how I did the demo. We don't do that anymore. And then we have measurement and monitoring. And this can go wrong. We're trying to collect data and keep track of it. So here's a few things that we can talk about. Are you showing me times? No. Thank you. 5 more minutes. So let's just do a few things. And so I talked about that we're getting data from a lot of these external systems. And so it's really important that you understand how these interfaces work. There's both two-way interfaces. That means I can send something to you, and like the patient's name, and then you can get a result, and you can send it back to me. That's a two-way interface. There's one-way interfaces where I can just send you the patient's name, and then I never get anything back. Or that I could have the patient walk over here and get their blood drawn, and sometimes you'll send the result back. But we only get one way of communication. So you can imagine one way of communication is not as good as two-way communication. We also have that, I call that sneaker net, when you walk your information. So many times, the doctor will give you the record and say, you take it to the other doctor. That's not very good at all. We've lost our interoperability. And then the last kind of way we do it in these EHRs is a lot of times there's a screen here and there's a link, and when you click on that link takes you to another computer. So it's really just, there's no integration other than what we call visual integration. So you actually are going to another computer and looking at it, and reading it, and then coming back to your own computer. So if you can imagine you're trying in a legal case to understand what happened, and you're looking at the records from this computer, the records aren't here, they're over here. And so you have to know where that data was so they can find out if they really looked at it. So, and there's also many different communication platforms. And so we used to have the telephone and voice. We could talk to each other. Now we have email, and we have messaging in the system, and then we have chats. There's cases where residents made Google Docs. I don't know if you ever shared a Google Doc with someone, but they'd make a Google Doc for every one of their patients, and then everyone would log on to Google, and they'd look at their patients on the Google Doc, and that's how they shared information. Rachel's laughing. That's not secure. That's not good. But it's so effective. I'm just telling you. The people that thought of that were brilliant. Google and the people that decide to use it. You talk about a workaround. Now you've got all this patient data on Google. And we're doing that a lot, those kind of things like that. And then we have a lot of data and audit logs, so you have to know which computers to go to, and then there's going to be audit logs in those other computers. And so sometimes the case is going to involve the data in the audit log, and a lot of times I'm involved in those cases. And now at times they send me 4 audit logs from the radiology system, their laboratory system, the main EHR, and we're trying to correlate those logs. And I don't know, like the most common error is that the people forget to change the time on the computer, and so the times are off by 1 hour. And so it's really hard when something really happened that happened at one real time, and now you got these 2 records and it looks like the times are off, and it's hard to figure out that the times are off by like a systematic error. We also have these what I'll call pre-populated charting templates. And so this is when you go to the doctor and you say, I got a cough, and the doctor pulls up an upper respiratory tract infection charting template. And because he quickly decides that's what's wrong with you, and you start looking at this template, and it's supposed to help him ask all the right questions. Are you coughing? Do you cough at night? Do you cough stuff up? I don't want to get onto all the stuff that they're supposed to ask you. There's a long list of questions. This is supposed to help you to remember that. You can imagine the problem is if I don't really have an upper respiratory tract infection, this is not a good thing to be doing because I could have something else that's causing my cough, like one of my medications could be causing my cough. So it's easy to miss items. And then sometimes on this thing, there's a button that says all normal, and they can click that all normal button. And if I walk into the doctor right now, he should click, well, except for my mental capacity, all normal, and doesn't even need to look at my heart because I'm standing up, I'm doing fine, I'm doing okay, I'm all normal. But sometimes they click that all normal and the patient only has one leg. and then they say something like, and I looked at the pulses on their feet, and they were fine, and then you get to the lawsuit, and there's this patient, walking there with one leg, and they said, "Doctor, how did you check the pulses on both feet? There's only one leg." And the doctor says, "I must have clicked the wrong thing. I don't know." And it really looks bad. So his charting templates can be bad. So I'm sorry you can't see this, but right here are those buttons. And that's what the doctor clicks. They say they're alert and they're oriented. They have no apparent distress. They click those things, or they can click that button that says all normal. And it creates this part up here. It writes something. This is called computer-generated text. So you write in a box, and then someone wrote a program that says if the NAD, which is no apparent distress, button is clicked, write down the parent is in no apparent distress. When you get the paper record, you see that top area that looks like someone typed it. And the doctor says, "I never typed that." Like, "Well, you signed it, doctor." He goes, "I never saw anything like that in my life. I clicked some buttons." And so it's very difficult. And as I've said many times, I'm most often on the defense side as an expert. When the plaintiff shows that screen and says, "It was right there that you could have clicked lethargic and you didn't click it. What were you thinking? Were you paying attention?" It's very hard to defend the fact that you didn't type something like that in when it was right there, one click. So that's really hard when you can see these screens. So if you can see these screens, you can find out what happened a lot. I mentioned about the printed record is not the same as what the doctor sees, that user interface. And it's worse than this because, a case, like the cases that I work on now, happened in 2013 or 2014, which was 5 or 6 years ago now. And the computer has changed in the last 6 years. So even if you ask to see the computer system, it's not the computer system, the same one that the doctor saw 6 years ago. And the doctor can't remember the case, can't remember anything that's going on, and it's really hard to see those screens, so you need to think about what you're going to do. And so sometimes you can find screens on YouTube, training videos, training manuals, but you want to see the actual screens that the doctor saw 5 years ago. And you talk about spoilage in cases, and you're supposed to save everything. We can't save our electronic record or anything like that. We can't seem to save that interface, and that's a real problem. And I think there's a business out there for someone that can figure out how to save copies of electronic records. And there's a lot of things that you can't see, so default values and intermediate screens and who entered data and things like that. There's this idea of metadata, and that doesn't explain why someone did it. And the metadata is just data about the data. So you can think about in the old days, we used to have envelopes and we used to send mail, and there was metadata on that, so you could see when the letter was sent. This was sent in sometime in 1920. You can see who sent it, this doctor, and you can say who it was sent to, but you have no idea what's in that envelope. You don't know if it was a love note, a bill, a refund, hair lock. You don't know anything about it. That's your metadata. And now you can just guess what that is. You may have cancer, you're going to have a baby, there's good news, there's bad news, it's all kinds of things. The metadata doesn't tell you anything about what's in it. But you can find out when the data was entered. So when they have a case where the patients say they were awake and alert at 7 p.m., and then the patient was found unconscious at 7:05, this is the record that you see. And then in the metadata, you find out that that first thing was entered at 11 p.m. by a different nurse from a different computer. And that really calls into question Nurse Ratchet's veracity, because she might have not actually seen the patient at 7 p.m. She might have written that down to copy it. So I will not talk about copy and paste. And these are some things that I remind you, they're complex, and I would urge you to ask a lot of questions when you have a case that involves an electronic record, and these are some to go. Thank you so much. It's been great being here.
Late as usual, Melman. We've discussed this in the past.
Slides. The other button. Yeah. One more. Oh, Here, wait, maybe it's right here. Maybe right there's one area.
Oh, I see.
Terry? Oh, I see him. There you go. Oops. It's not gonna. You want to do it this way. Don't turn it around. Oh, you have it now. You sit return. I think you want to. Yeah, there you go. Oh, no. Try again. There you go. All right. Now, and then if you go up there to.
So do you notice that most EHRs are designed by Microsoft? Because in PowerPoint, the button that you would use the most is this one, right? So it's the smallest and the furthest away. And yes, I'm a Mac user. What an embarrassment. Well, hello, and thank you for inviting me. So in a recent, you can start the timer now, Sharona. And good luck. In a recent Fortune feature, Death by 1,000 Clicks, Fred Schulte and Erica Fry describe what they saw as, quote, a tragic missed opportunity. Rather than an electronic ecosystem of information, the nation's thousands of EHRs largely remain a sprawling, disconnected patchwork. Moreover, the effort has handcuffed health providers to technology they mostly can't stand and has enriched and empowered the $13 billion a year industry that sells it. In a nut, the question I pose today is whether there is any chance of EHRs successfully morphing from being the endpoint in a bumpy shift from paper to digital records to undergirding the next major healthcare revolution, which is data-driven, artificial intelligence, machine learning-based healthcare. So first, a roadmap. I'm going to do the history of EHRs for the last 10 years in about 4 minutes. I'm going to do the present, a sort of a deeper dive into current proposals for better sharing with patients and other professionals, and then talk about the future, the role of AI-infused EHRs in improving healthcare administration and their emergent role providing the training data for next-generation predictive diagnostics. So first, a slide that gives you the last 10 years of history of EHRs. Very quickly, we think of paper records as existing forever. In fact, documentation didn't really start until the 1920s with document standards driven by what is now the American Health Information Management Association. Those records first started appearing about a decade later. Fast forward 50 years, I told you it'd be quick. You get the development of the PC that brought information technologies to most other businesses, but you had to wait until the 2000s, until President Bush's first term, that broad replacement of paper records was viewed as a goal. The immediate past history of modern EHR starts brightly in 2009 with the HITECH Act, a meaningful use subsidy program designed to counter what was perceived as a market failure problem. Only later did we find out it wasn't a market failure problem, it's that EHRs were crap. Oh, I'm sorry. Did I say that out loud? So taxpayers spent $300 million to seed nationwide health information exchange, $35 billion for meaningful use subsidies. Upon passage of the Medicare Access and CHIP Reauthorization Act of 2015, a MACRA to those of you loving acronyms, the meaningful use sticks got rolled into CMS's merit-based incentive payment system known as MIPS. Soon, however, we discovered there was a good use for EHRs. Fraud. We've had two major false claim settlements with EHR developers, one for $155 million, another for $57 million over false certification of their products for meaningful use standards. Other false claim settlements have arisen from providers using EHRs to cut and paste claims and enable upcoding. And in mid-March, a juicy new Key Town False Claims Act case was unsealed in Florida, alleging attestation oopsies by a for-profit system that had netted more than $450 million in EHR subsidies. Not to be outdone, the Office of the Inspector General in a 2017 report alleged that CMS paid an estimated $729 million in Medicare electronic health record incentive payments to eligible professionals who did not comply with the federal requirements. As meaningful use, MU, kicked on, soon The design and implementation of EHRs snatched defeat from the jaws of victory, as EHRs found themselves beset with interface issues, synaptical complexity, lack of interoperability, workflow incompatibilities, errors, and alert fatigue. In a Health Affairs article late last year, Raz Ratawani and colleagues reported on a multi-site analysis of 9,000 patient safety records. 36% had a usability issue that contributed to a medication event. 18.8% might have resulted in patient harm. But we can solve these technological problems. Soon as the patient became secondary to the enterprise, as the EHR and the computer interface dominated the examination room, Abraham Verghese coined the word iPatient, noting now how, quote, it threatened to become the real focus of our attention, while the real patient in the bed often feels neglected, a mere placeholder for the virtual record that the physician is examining on the computer screen. But as I said, there's always a solution. What was the solution for healthcare stakeholders? To employ scribes and to assign them to doctors. And these scribes now fill in the EHR field while the doctor examines the patient, because nothing says empathy better than showing your new rash to a recent graduate from stenography school. From usability impacting safety to full-on safety concerns. Last month, the ECRI's annual top 10 patient safety concerns included at number 1, diagnostic stewardship and test result management using EHRs. In August 2018, the Pew Charitable Trust, the American Medical Association, and MedStar Health issued a joint report arguing, quote, unlike many other high-risk sectors, such as the airline and medical device industries, there is no standard for routinely testing healthcare software for safety issues, and instead they proposed voluntary certification tenets and test cases. Of course, airline industry analogy may be a little forced at the moment. I have a piece that should be on the Bill of Health blog at Harvard coming out on that very issue, I think, tomorrow. So, in short, EHRs make mistakes like others in our fragmented healthcare system. One piece of technology doesn't talk to another, or an important signal gets lost in all the data noise. And it's increasing. Almost from the launch of meaningful use, questions have arisen about the lack of interoperability, and even a version of that with malicious intent called information blocking. For example, disputed allegations that developers such as Epic used App Store terms about API use, application programming interface use, to acquire its customers' data. More on information blocking and so on later. And finally, not too hard to understand, as the EHR grows, this vast computer network grows, so the data it possesses becomes even more voluminous and deeper in coverage, social determinant, financial data. So, as that goes up, its value on the dark web goes up. And that's why we get more hacking. Hacking and ransomware stakes have increased dramatically. 5 million patient records were compromised by cybersecurity breaches in 2017 compared to over 100 million in 2015. But the number of healthcare breaches increased 10% over the previous year, suggesting that while larger entities are getting better at security, the hackers are turning their attention to smaller providers. So, that's the history of EHRs. So now to sort of talk a little bit about the present and better sharing with patients and other providers. So under the Trump administration, the MIPS program that took over from Meaningful Use has been softened somewhat. Additionally, MU has been rebranded as Promoting Interoperability, although it does retain its place in the value metric at 25%. The 2019 measures are subdivided into 4 reportable objectives against which providers have to report: e-prescribing, health information exchange, provider-to-patient exchange, and public health and clinical data exchange. That promoting interoperability metric is one of the pillars of CMS's My Health e-Data initiative. Further, we have proposed CMS conditions of participation that would mandate patient access to claims and health information. The 21st Century Cures Act, the most bloated piece of congressional hubris it's ever been my misfortune to have to read, required HHS to promote interoperability through notice and comment rulemaking. The NPRM dropped in February, with interoperability defined as enabling the secure exchange of electronic health information with and the use of EHI from other health IT without special effort on the part of the user, and allowing for, quote, complete access, exchange, and use of all electronically accessible health information for authorized use. Whew. Now, this builds on HIPAA's access right and interoperability provisions that were introduced during the latter stages of meaningful use, but then obviously beefed up by Title IV of the Cures Act. The technology play here is around application programming interfaces being built into EHRs, most notably the Fast Healthcare Interoperability Resources, FHIR, which is pronounced FHIR, the FHIR standard, which is developed and maintained by the HL7 Standards Authority. Today, FHIR is the API of choice for major EHR developers and technology companies leveraging it, such as Apple. Under the proposed rule, EHR certification will be dependent on frictionless export of data to a different EHR provider, and also patient access to their own data. Of course, the $64,000, although I suppose it's now the $64 billion question, is whether patients will use the data when it's deliverable to and organizable on their own devices, rather than being a series of fragmented snapshots that they can get through individual physician-patient portals. The second question, if data is so delivered and combined, will it improve patient engagement? Or will fire go down in flames, as yet just another sort of failed experiment in consumer-driven healthcare? Finally, a quick mention of another frame for interoperability. Policymakers are tending to see EHRs as a jack of all information trades. If you have a problem, let's try and solve it with the EHR. The most obvious current example of this are state laws that are mandating the interaction of prescription drug monitoring programs, PDMPs, with EHRs. Typically, they had separate interfaces. Insofar that this is a good tactic, actually it's only marginally good, but that's a different talk that I'm not giving today, in dealing with a major problem like the opioid epidemic, I suppose I can support it, but how far do we want to go? By the way, for anyone who wants a good paper to write, there's a lovely little brouhaha brewing, because CDC and DOJ are telling folks who want to take their grant money for opioid integration, interoperability, that they have to use a specific government-financed and developed data hub, while all the states have signed on with a for-profit monopolist, APRIS, who is doing all the integration. And so there is a splendid little fight that's about to happen now. All right, information blocking. Cures Act Section 4004 addressed this, and this is also included in the 724-page, 724 pages? Really? 724-page NPRM. Information blocking is, of course, today's teenage sex. Everyone talks about it, nobody is entirely sure how to do it, and everyone thinks everybody else is doing it. I think there's a very good argument that, in fact, those who claim blocking do so as a convenient excuse for their bad technology and fragmented care models. The proposed regulation on information blocking hinges on Sienta-based interference with information sharing, but it provides 7 safe harbors of reasonable and necessary practices, such as preventing harms, promoting privacy, or dealing with infeasible requests. Writing on the Health Affairs blog, Lucia Savage, who served as the ONC's Chief Privacy Officer under the Obama administration, noted that some safe harbors, such as the proposed safe harbors, such as internal privacy policies, were arguably what started the whole blocking kerfuffle in the first place. The good news is that patients can't be charged for accessing APIs with their own apps. The other good news is that following the Cures Act instruction, the ONC NPRM also prohibits most developer gag clauses for EHR service contracts. So on to what I'm going to call HIPAA 3.0. The story of EHRs has always been inextricably linked with HIPAA. The original privacy and security rules were born out of administrative simplification in the 1996 Act, and the mass adoption of EHRs was a result of the High-Tech Act. It seems an age since HIPAA 2.0, the High-Tech Act and the Omnibus Rule. But there may be EHR-related HIPAA changes coming our way. Secretary Azar, in a recent address to the AMA, described HIPAA as, quote, one of the regulations that need to be re-examined to give you, as physicians, on the front lines, the freedom to deliver better value in our healthcare system. A December 2018 RFI from the HHS Office for Civil Rights asked for input on 5 areas, including improved care coordination, addressing the opioid epidemic, and accounting for disclosures. Oh, it's back! Accounting for disclosures is back! We're so happy. I'd say, so watch this space, although Politico reports apparently that there is absolutely no agreement amongst any of the responses to any of the questions. I don't know whether that's true, but it will be fun to see what they come out with. Also watch out for renewed proposals to try and better align the confidentiality of alcohol and drug abuse patients' records, 42 CFR Part 2, often just referred to as Part 2, or the substance use privacy regs, to see if they can be better aligned with HIPAA. Part 2 provides an additional layer of confidentiality for the records of substance use disorder patients. And historically, HIPAA Part 2 has required an additional highly specific consent from the patient before sub-records may be shared. Legislation to change the sub-rules and better align them with HIPAA were included in the House version of the support bill last year, but didn't survive reconciliation and was omitted. It's now resurfaced with some bipartisan backing, but Representative Frank Pallone is now chairing House Energy and Commerce, and he opposed the bill last time, so I'm not sure I expect much action on this side. We made some our opioids team made some recommendations that a lot of this could be done with joint enforcement guidance from OCR and SAMHSA, and we can talk about that if you're interested. So let's turn to the future. First, what is known as robotic process automation, which is kind of scary. Atul Gawande described our current generation of HIT as, quote, I've come to feel that a system that promised to increase my mastery over my work has instead increased my work's mastery over me. Clearly, one of the negative impacts of EHR adoption has been the shift of administrative tasks to physicians, resulting in workforce misalignment and with clinicians not practicing at the top of their licenses. Now, while hopefully EHR interfaces will see continued improvement, AI-based systems offer the real promise. In hospital and physician offices, we will see the increased use of robotic process automation. This is sort of AI used to automate drudgery, if you like. The automation will apply to routine or mundane office tasks, such as making appointments, billing patients, checking in patients, but now using face identification. Natural language processing and digital assistants will take over note-taking and eliminate the need for scribes and so on. Think of it this way, it's not directly related, somewhat tangentially related to EHRs. Why do we have waiting rooms? Why do we have waiting rooms? They're a hack, right? In the words of A.J. Agrawal and colleagues in his book, Prediction Machines, they're one of our imperfect solutions to uncertainty. AI administrative, and once you see the waiting room issue as a prediction problem, then it's something that you can apply AI to. Once AI administrative and clinical systems can read data from each other, combine outpatient data, appointment data, combine check-in data, data about historical visit lengths of particular patients, cross-check local traffic conditions, and accurately predict flow and how many workers turned up that day, you can replace the uncertainty with accurate prediction. and then you either can get rid of the waiting room completely or make it just have one seat, right, as you're being roomed. Next, EHRs training data. EHRs have long been seen as involving more than data storage. For example, the IOM long ago recommended the collection of long ago in EHR history, long ago recommended the collection of social determinants of health, such as data such as education, financial resource strain, stress, depression, physical activity, socialization, intimate partner violence, and neighborhood median household income. Notwithstanding, EHR data remain primarily small data, although in large healthcare domains they may look like big data, and of course frequently are mixed with high volume, velocity, and variety slide data. AI has three data types. First, training data, which is used to generate the algorithm. Secondly, input data, which is fed to the algorithm to produce a prediction. And three, feedback data, which is used to improve the algorithm's performance in a continually machine learning feedback loop. In AI, EHR records are the training data. For example, one proof of concept study used almost 250,000 electronic patient records, including clinical notes, so unstructured data, from 2 different hospitals, totaling almost 47 billion data points, and achieved high accuracy in predicting in-hospital mortality, unplanned readmissions, prolonged stay, and final diagnoses. In the UK, one of the broadest and also quite controversial applications has been the Streams, an algorithm, an app running on Google's DeepMind that has been trained on more than 1 million patient records held by London's Royal Free NHS Trust. And that alerts clinicians without doing more about the likelihood, high predictive value of acute kidney disease in their patients. If training data are the new oil that everyone wants to drill for, EHRs are Texas. So to predictive diagnostics. As platforms, EHRs have long been more than addressable databases. Computerized provider entry, or CPO, was quickly integrated to facilitate prescribing, but also to warn about drug interactions. Now we have PDMP interaction and so on. Heretofore, as Dean mentioned, the practice of medicine has been dominated by heuristics and rule-based systems. The former, while efficient in that they quickly access already cached data, cached up here, and apparently similar decisions, they're incredibly prone to cognitive bias. Of course, AI has its own bias issues, including the cognitive biases of its programmers and the skewed data sets used for training the AI. However, it should comfortably outperform heuristics. Rule-based systems, for example, the if-then rules in clinical practice guidelines or in rule-based clinical decision support systems, typically are derived from quite gross comparisons of inputs and outputs. Once these issues are understood as prediction problems, then properly trained AI can be used to make far better decisions that are not frozen by rules, and as the AI makes more decisions, continually improve the predictive algorithm and the decision-making such that far more precise choices, indeed a form of precision medicine, results. In a blog post last year entitled Deep Learning for Electronic Health Records, the Google AI team reported using deep learning models to make a broad set of predictions relevant to hospitalized patients using de-identified electronic health records built on top of the FHIR API. One example, a deep learning model was used to render a prediction 24 hours after a patient was admitted to the hospital. The timeline, which you can see on the, impossible to read, I'm sure, it's probably not even the correct image. I probably just made that up, but it is actually from their study. The timeline, the top of the figure, contains months of historical data, and the most recent data is shown enlarged in the middle. The model attended to information highlighted in red that was in the patient's chart to explain its prediction. AI is particularly adept at pattern recognition, making it a natural fit for reading scans. And as algorithms become more powerful, their roles will evolve from the descriptive to the diagnostic to the predictive. At some point, the analytics likely will turn prescriptive, with the AI itself deciding to execute a task. As the amount of data that is fed into AI increases, so generally does its predictive abilities. Many of the most important breakthroughs, therefore, will depend on feeding the AI, hence the EHRs as Texas claim. I do have some thoughts about privacy, but out of respect for the flag-waving individual in the front row, we can maybe talk about the latest revelations about Facebook and its feeding itself from what appear to be private apps. And so let me just conclude. This is now going backwards. The revenge, that's right. So finally. So I thought I would end by turning to the bard for a summary of my thoughts about EHRs, past and future. Obviously, this is Hamlet, Act 5, Scene 1. Thought you might like a little culture. Alas, poor EHR. I knew him, HIPAA. A fellow of infinite data storage, of most excellent blocking. He had borne my data in his interface 1,000 times, and now look where Moore's law has taken us. Me and my scribe are properly upset. Here hung those tabs and drop-downs that I clicked on to no avail. Where be your decision support now, your alert fatigue, your crashes, your tempting false claims of oversharing that were wont to set the Office of Civil Rights on a roar. Not one now to mock your own API, quite chap-fallen, mere training data for our future computer overlords. Thank you.
Right, so despite all that abuse, I'm going to
That was good.
question and answer. And we do have a microphone, so if you have a question, just raise your hand and we will get it to you. But I'm going to start with the first question, which is, did we make a mistake transitioning to EHRs? Were we better off in the paper era?
No, it was terrible. I don't know if everyone remembers the paper era, but we lost a lot of data, and we never had our records. When you went to the doctors never had them. It was not good. We couldn't read them. There were many studies that showed between 10 and 15% of prescriptions were illegible. That was like the biggest joke, is a physician's handwriting. So we've eliminated all those problems, and so we're probably now at error rates of around 1%, where we were before at least at 10%. And so we made maybe 10 times improvement. It's my opinion.
Yes, I suppose that's correct. I think, like almost everything in U.S. healthcare, we always start from the wrong end, right, in trying to fix something. So the greatest problem, illegibility, those kinds of record errors aside, which were acute, and have been dealt with very well, I think, by EHRs. The primary problem that we were facing was lack of coordination, fragmented care. That it wasn't so much that records were paper, it's that there were 27 sets of them scattered across different offices. And so we tried to fix our fragmentation problem with EHRs and then interoperable EHRs. And, trying to fix the wrong problem will usually end up badly.
So we replaced legibility with intelligibility. So when you have your doctors doing all sorts of clicking and dictating, and they're not actually telling the story, you're ending up with something entirely different. So number one, I do think that scribes can be very useful, because one of the biggest problems that we've had is the doctors have stopped attending to the patients and started attending to the computer. So scribes actually are a good way of getting back, and they increase both patient and doctor satisfaction. But my question for you is this: the predictive utility of it with garbage in, garbage out. So now what happens is we're putting in a lot of documentation that's not really telling what's going on with the patient. So how exactly are the computers supposed to be able to do their natural language processing when the data's not good?
So you're right as far as the present, but the whole point, the promise, but with it a lot of concern, the promise of AI machine learning is that its ability to read everything, including unstructured data, allows deep dives into that data with dramatically improved prediction handling, and that it will learn increasingly to discriminate between the garbage and the non-garbage. It will do a lot of things that we as humans are not particularly good at. It will be far better at reading scans than we are. It's far better at reading all of that data, of taking all of that output than we are. We do not have time in our lives to do that. The question is, can we design these systems with sufficient sort of moral or ethical bases and programmed in safeguards such that in improving the efficiency of the system, we don't just move to a technocracy, but we still maintain a role. It may not be a physician role anymore. It's like there may not be lawyers anymore, right? But we maintain some sense of systems that protect vulnerable persons, that have some sense in a modern computerized world of beneficence. And we can work through that.
I would second that. I worked on a project. I worked at Kaiser Permanente, which is a managed care organization. And one of our projects was to identify patients that should go to hospice. And the reason you go to hospice is so you can have a pleasant death as opposed to a terrible death in an ICU. And, in our organization, the people that went to hospice stayed on an average of 3 days. And so what that meant was that we weren't recognizing them soon enough. And so we wrote some programs and we could recognize people that should go there. Medicare will pay like for 6 months or so. We recognized patients that could do that and we could recommend them. And when I showed it to my boss, he didn't think that was going to be a good selling point, that Kaiser could predict when you were going to die and would send you off to die. And, that would save us a lot of money in Kaiser, but it would also make your life better. And so now the question is, you're going to die in 6 months. I'm going to make your life better. How do you feel now? It just doesn't quite work. And so what we're going to do with these predictions is going to be very interesting. I mean, most of our predictions now, I can predict very well based on your age and your weight and whether you smoke and whether you drink and whether you exercise and what you eat, how long you're going to live. But no one wants to hear that because changing all that stuff is really difficult. And so now that the computer can do it, are you going to stop smoking and drinking?
You saw that, I think it was CNN had a piece about a physician used one of the teleport virtual physicians with a screen to tell a patient that he had like 3 hours, 3 days to live or something, and it's through a computer interface. The one thing I do hope that does fix, however, is the moral problem I have when I put someone's birthday into my calendar, and it always asks, what's the end date? And morally you feel you have to say never. But wouldn't it be great if the computer could just fill that in for you?
Yeah. Yes, absolutely.
So, thank you. And Mr. Terry, since apparently you have some kind of God-given talent or curse to read legislation, one of the things that's been fascinating about watching the arc of things in health IT over the last 20 years has been the apparent absence of lessons learned in other industries, like just referencing we're sitting here at the home of Standard Oil, and when the oil industry became a cartel and became damaging to the nation, we didn't turn to Standard Oil and say, how would you fix this? In contrast, we have entities that are nominally supposed to keep in oversight of the patient's best interest in the healthcare setting. For example, the FDA and FTC. How is it that they got short-circuited and allowed the promulgation of systems that were acknowledged decades ago to be unsafe, non-secure, and not designed to promote patient care? How did that occur at the oversight level?
I guess carrying on from where I ended, but in a different play, I came to bury the FDA, not to praise it. In fact, the opposite true. I think the FDA actually does an extremely good job with relatively limited resources. We have seen, certainly in the device space, over the last 2 or 3 years, a dramatic increase in the number of devices that are approved on a monthly basis, which is giving some folks pause. And I did allude to the Boeing issue a little while ago. Some of the questions that have been asked about FAA certification being moved away from the agency into the Boeing plant and to Boeing employees. We don't have the full truth on that yet. It's newspaper reports. And I did think, and which is one of the reasons I wrote this new piece for Bill of Health, that there was a sort of an eerie parallel there to the soon-to-be departed, not in the sense we were just discussing, the soon-to-be departed Scott Gottlieb's pre-cert program for digital products, whereby you essentially certify the manufacturer rather than the product itself, and that's in pilot with Apple and Samsung, Verily, the Google X subsidiary, and so on. So my concern is less about the quality or the ethical base, the professionalism of the FDA, which I think is very good, and more about whether we are giving them the right criteria to judge these kinds of technologies going forward. The FDA is basically looks at risk and efficacy. It doesn't, for example, look at cost effectiveness. It doesn't look at empathy, right? If it's approving an algorithm.
Often is a much smaller percentage of our overall cases. So we do believe we see some correlation here between electronic health records and the percentage of these cases where there is a medication management problem. Jumping ahead to factors that contribute to patient injury are identified by the physicians who review these cases for us. As a medical malpractice insurance company, most of us do not have the clinical expertise to look at a case and determine whether the care provided was appropriate or not. If it was not appropriate, using the reasonable man standard, then there is liability if we can connect the causation there. So when we look at these cases, we are trying to find out from these physicians whether there are issues that we need to be aware of or that we can either defend or that would prompt us to settle a case. So as you're looking at these these technology and design related issues, I always do the palm of the hand to the forehead when I look at that number 1, technology and design issues other. That says to me, it's number 1, that says to me that our taxonomy is not robust enough to capture all of the issues that we are starting to find in electronic health records. So it is frustrating, but we are working to improve the taxonomy and hopefully to be more specific than placing them in another category. The next one is failure of the technology in the EHRs. You all know and experience that, so you know how that works. Decision support or alarms, we'll have a couple of cases we'll share with you about where there were no alarms, didn't capture simple errors that were inadvertently made. Fragmented electronic health records often refers to where there are multiple platforms for this healthcare information that don't talk to each other or don't talk to each other perfectly, or the transition from a paper record to a digitized record. So let me give you a few examples of the cases that we've seen. With 199 cases, it's always hard to pick a few that are representative, but some of these are significant and some of these are rather insignificant. But in this first case, an elderly female presented to her otolaryngologist for sinus complaints. He ordered Flonase nasal spray. She used it for 2 weeks, developed some dizziness, ended up in the emergency department, and they discovered when reviewing her meds that she was not taking Flonase but Flomax, which is for prostate problems. And I don't think she even knew she had a prostate problem. So the ordering physician typed in Flo, and of course the autofill filled in Max instead of Nase, and so she ended up with the wrong medication and ended up in the emergency department. Fortunately, no other more serious sequelae than that. In the next, oops, I didn't even show you the case, sorry. Then in the next case, a female with a bladder sling inserted for urinary incontinence. Her surgeon was assisted by the proctor surgeon from the manufacturer. It was a new product, and so the surgeon needed someone there to work with him. There was blood in the patient's Foley catheter after surgery, so they recognized they had punctured the bladder, took her back to surgery. Patient had a rocky recovery, ended up filing a claim. And at some point during the discovery process, they learned that there was this other party in the operating room that they did not know about because it was not documented in the record. Was this someone's fault? Well, as they looked at the system, they realized that the pull-down options in the OR documentation did not include any guests, other experts, manufacturer representatives, etc. And there was no free text field, so the nurses who were doing the documentation couldn't figure out how to address that issue, so they ignored it. In our third case, we had a 55-year-old male who presented to the ER with back pain. He was diagnosed with severe lumbar stenosis. He had successful surgery. However, the nurses noted over time that he was experiencing neurological changes. They documented this, and they also reached out to his reportedly attending physician. They didn't get any response from this physician over time, and finally discovered that the reason that they didn't was that they were contacting the wrong physician. In the transition from paper to the electronic record, the correct physician's name had not been entered. And this delay they attributed to the patient's resulting paralysis. In our fourth case, a 50-year-old female was diagnosed with left kidney failure due to hydronephrosis secondary to a kidney stone. Now, early on, she was sent to her nephrologist who placed a stent, and she had some success with that. But over time, the condition of her kidney deteriorated, and it was determined that she needed to have it removed. So her attending sent a letter to the nephrologist stating that she had a right kidney failure when it was actually the left kidney failure. Now, the surgeon, the nephrologist, scheduled surgery to remove her right kidney, and normally would have gone back to his own records because he had treated her before. He would have had information on that, but he was in the middle of this transition to a new office, and so his records were not available, and so he did not confirm the correct kidney, and so the wrong kidney was removed. Looking now at user-related issues, you can see incorrect information in the electronic health record. I am very grateful for spell check because whenever I read my emails and my other documents that I type, there's always incorrect spelling and sometimes incorrect information, so I can see how that happens. So I'm not sure what the electronic health record can do about that if we're entering incorrect information. But prepopulating and copy-pasting into electronic health records is a recognized problem. We're encouraging physicians that we ensure not to do that, to the extent that they do that, to review it carefully to make sure it's an accurate representation of the patient's current condition. And then we have these conversion issues, as we've talked about, although I look back over our last 8 years to try to see when the most cases involving electronic health record had been filed, and we saw them peak in 2013. And then there was a drop-off with a smaller peak in 2015, and then they've continued to drop off since then. So I'm hoping that that's an accurate reflection of what's actually happening in the industry. But let me give you some user-related cases. In this first one, we had a physical medicine physician following a patient with extreme weakness due to a cervical vascular malformation. The nurses and the physical therapists who were seeing this patient on a regular basis were noting changes and documenting them in the chart, but then they would go read the physician's record, and the physician indicated that there were no changes. Eventually, they became concerned because the changes were significant enough that the physician did not seem to be recognizing. And once they contacted the physician, he ordered a neurosurgical consult, who took the patient immediately to surgery. But the patient then ended up with an incomplete quadriplegia. Again, assuming that or determining that the delay caused this patient's problems. The physical medicine physician was criticized in this case for copying and pasting the same note for 4 days in a row, which they believe delayed the intervention. In our second case, the patient was getting trigger point injections and also getting oral opioid management, and our physician went to order 15 milligrams every 8 hours. The pull-down menu offered two options. The second option was inadvertently clicked, 200 milligrams. Then the patient took their first dose along with his Xanax, developed slurred speech. They thought she was having a stroke, took her to the emergency department, where she did recover, but she ended up with an overnight stay and the costs associated with that, and so she wanted compensation for that. I can relate to that pull-down menu, clicking on the wrong item. I've done it myself. In fact, when my wife orders things off of Amazon, we often get two of them. I haven't quite exactly figured out why we get two. And sometimes we get something we didn't even anticipate, which is kind of a fun surprise. But then we have to pay for it. So, then in our third case, we have a 38-year-old obese patient who presented for medical clearance. He was scheduled for surgery, and his primary care doc checked him over and said, "You're okay to go to surgery." Had a successful surgery, but then 3 months later came back to his primary care physician with shortness of breath and dizziness. His blood pressure was fine, but his pulse rate was very high. And apparently, this physician did nothing about it. No tests were ordered, and 5 days, this patient was released. 5 days later, he expired from a pulmonary embolism. So when this case was being reviewed, the experts questioned whether the physician had conducted a complete assessment, because the progress note related to this most recent visit was identical to the progress note that he had documented in the very first visit prior to his surgery, with the same old vital signs and the same spelling errors. So we knew that was a problem. So with that, let me turn it to Scott, who's going to talk to us about EHR adverse events and the investigative process.
Okay. Well, that's fine. Yeah, we can keep it in there. Okay. Thank you, Daryl. Hello, everybody. Yeah, it was a very good talk. I appreciate that. It was awesome. It's a pleasure to be here. I'm recovering from a bit of a head cold, so at one point I aspired to have a cool, raspy voice. Yeah, this is not the real deal, but so I'll get through it. But anyways, thank you for this opportunity. I mean, what a great brain trust we have in this room on this topic, and so kudos to the folks who organized this, and thanks a lot for allowing me to be a part of this. I've come from I'm sort of a mutt in the accident investigation world, and I'm an engineer by trade. I started in the automotive industry in biomechanics, injury biomechanics, some DoD work. In the past, somewhat new to healthcare. In the past 10 years, I've been at ECRI Institute doing accident investigations at ECRI. So what I try to do in talks like this is sort of bring some common themes together and discuss investigation approaches from a system safety perspective, realizing that healthcare is unfairly compared to other high reliability organizations at times because we have this variable biological system in the patient that is multi-complex, highly unorganized and changes day to day. So that's just a caveat. But a little bit about ECRI. So we are a nonprofit. We've started by evaluating medical devices, somewhat similar to consumer unions. Consumer Report does for consumer products. So this was done prior to FDA regulation, 1968. This was really a need at the time. We've grown to all sorts of other different things: consulting, government funding initiatives, EHR, health IT. Accident investigation. So my group, I'm responsible for the investigation services where we go to hospitals on site when there's been a patient adverse event to try to figure out what happened and offer recommendations on recurrence. We're no stranger to adverse events. We have several different conduits where we're receiving problem reports. So some of the stuff I'll talk about today comes from our Health IT Partnership Initiative that has been a conglomerate of vendors, clinical practices, hospitals, you name it, other nonprofits, to kind of come together and establish these working groups on particular topics. So we talked about copy and paste already. That was one of the first reports that came out. I'll mention a few others as we go through the process. But I'm somewhat presenting some of this data third hand, as this is a dedicated team at ECRI that comes up with this data. All free, by the way, so it's free. The reports are free for those who want to look into it. So I'll go into somewhat on EHR patient safety, some of the key data from the partnership and our ECRI PSO database. That's up to about 3 million reports probably right about now. Talk about system safety, because I think that sometimes when we think about investigating an EHR event, it's very easy to get hyper-focused on the EHR, who did what when, which is obviously important in a med-mal case. But from a patient safety perspective, where does that fit into the overall system? And then how do we get to the contributing factors when we consider that system? So I'll go into that a little bit. And then where do we go from here? Like how do we get to the promised land? Yeah, we had a couple great comments and commentary on the earlier talks today on how do we get there. So I'd like to kind of hear from you what you think about that. All right, so when we talk about these millions of problem reports and all these events, taxonomy is so huge. I mean, understanding what is a contributing factor and having that common format to report back to whatever organization, whether it's internal, external, to make some sense out of this data. So first we got to define, well, what is a health IT event? Is this patient safety event actually a health IT event or something else? So there are all sorts of definitions out there now. This one is one that's kind of stuck with me. Basically, these errors would not have occurred but for use of this technology, health IT event. Okay, so that can kind of get started on an algorithm of reporting so that we can get the proper contributing factors and then have the feedback to help improve that system. Okay, so are these health IT related events? Well, we have a physician ordered the patient anticoagulation medication being discontinued. The order did not cross over to the pharmacy system. All right, and then long story short, the IT department says, well, that's going to be resolved with the next software upgrade. Okay, is that a health IT event? I'd say yes, absolutely, right? So there's that communication platform, that middleware, sometimes people call it, that connectivity between where the physician is ordering that to the pharmacy. That's problematic. We talked about that in Dr. Sittig's talk earlier, which was great. So that's a health IT event. So then we can start our algorithm of problem reporting and get it to the proper contributing factors, in this case, the middleware for that event. All right. Another example on the right side, the blue screen of death. The surgeon trying to access PACS while in the OR. Can't see it. Maybe it's the spinning circle of death. It's always something of death, right? So what happened here was the troubleshooting occurred in the OR while the patient's under anesthesia. So the extended time of anesthesia is the event in that case. Otherwise, it turned out just fine. But that's definitely a health IT related event, right? So one conduit of problem reports to ECRI has been through Hazard Manager and kind of a pilot program through ARC. And we ended up receiving a bunch of events and titrating those to what were considered health IT events and having the contributing factors binned up. And some of this data is consistent with the data we've seen already today. I mean, no surprise. So usability, that's high on the list. 24% of the reports are related to usability. Implementation, though, is pretty high too, 22%. So the implementation, that's like, you go to another hospital and you see the demo, but then you have to bring it back and implement it at your hospital. And what do we do to match the workflow at our hospital? So that's a really, growing pains to get that done well. Vendor factors, those are some obvious technical issues, decision support tools, as we talked about earlier. So I'll go into a little bit more detail on this. But data quality is another one, right? So the quality of the data, I mean, garbage in, garbage out is one way to think about it, but actually computing the data and outputting that data, the data quality is so important. So for example, an EpiPen. If you don't have the option to have an adult dose and you want to order an EpiPen for an adult, what are you going to do? The concern there is the dose will be too low if the patient actually needs to use that EpiPen, right? So that's a fix that was observed while placing that order, so this didn't result in an event, but that's a report that came through the system. And then the Twitter phenomenon, free text fields or flow sheets when you're trying to write things in and you run out of characters and it truncates. I mean, that's just come on. I mean, you're limited by the data you can put in, and so that truncated data is propagated throughout the rest of the system. All right, data quality. And if you get in, you can categorize this even farther, data quality issues, and get to things like faulty reference information and all sorts of other more specific terms under the realm of data quality. So then we can start to say, all right, how do we fix these things? After these millions of data reports come in. Usability. This is a topic that I really find very interesting from a human factors perspective. So usability are things like, extra medication doses given to patients. Even though these were documented, the documentation was not readily visible to the staff. So the data is okay, it's there. It's just not visible or easily obtainable. So that's a usability issue, right? Understanding the user computer interface and how the user wants to retrieve that data. That's certainly a usability issue. Electronic medication reconciliation. So this is talking about transfer of the patient, understanding the meds that are required for that patient transferred across the continuum of care. So we've seen fall-offs in the transfer of the patient as well. Extra doses of, for example, prednisone. If you're on prednisone, you want to get off prednisone, generally. So that's just an example. All right, and then you get into all these, again, subcategories of usability. So confusing information, mismatches between workflow and health IT. I think that the top two or three, well, the mismatch with user expectations, that's like the disappointment thing. Like, I wish it was better. I relate it to, like, I have young kids. They all think they're gonna go to the NBA or professional soccer, and then one day they realize, oh, I'm just as good as the rest of my buddies. Like, I'm not, I thought it was gonna be better. So anyways, that's kind of, we had all this promise. It was going to be better, so that managing the expectations. So I think those top three, over time, will be able to get shorter. We'll get less and less of those issues as a contributing factor under the realm of usability. I'm an optimist sometimes, though, so we'll see. Human factors. So let's step back. So this kind of is an industry-wide thing. It's not just EHR. It's not just usability within EHR. But human factors is its own science, and it spans across all industries, and it can mean different things to different people. So again, I come from the injury biomechanics world, so I think about anthropometrics and biomechanics and ergonomics and that kind of thing. From a design perspective, it's really a safe design that's not prone to causing misuse. So when we do an accident investigation, sometimes we're asked, is it a design defect? Is it a user error? Is it one of these things? Is it this or this? And often it's all. I mean, it's a system issue. It's a defibrillator that was put into out of cardioversion mode and fired a defib on a patient that wanted an elective cardioversion. I mean, it's those things. It's a design issue that predisposes that user error. right? So it kind of can be both. And we're really in this area in between the human and the machine. That's usability, that's human factors. As a human, we can perceive and compute in our brain what we see in front of us. And then that prompts us to take action. We put that action into a machine, it does its thing, it processes, and this is what we talked about, garbage in, garbage out. If we're not feeding the machine correct information, we may not get correct information out of it. All right, so I get asked this kind of a lot. My full-time job is investigating serious and fatal incidents in healthcare. So is healthcare safe? I mean, and sometimes I get the question, are you going to go get that surgery that you need? No. And I'm like, well, maybe, but I'm going to push it off, So, but no, I mean, really, like we talked about before, healthcare as a whole is safe. I mean, the denominator is massive. Human performance is generally really good. Technology is generally really good. So human error is a symptom of some kind of system issue, and we as humans can fix that system, right? So we can't rely on technology necessarily. This is an iterative process. So I think that we should give ourselves the confidence to fix that system and become resilient and adaptive. In the context of EHR, it's going to take a while to get there, but really we're the drivers of that. So as an investigator, we want to go in and we say, what made this system hazardous? The EHR is a critical piece of this, but how is it being used, in what context? What were the stressors? What was the workload? How many procedures were performed that day? Those kinds of questions can really reveal some of the other issues. So this is complex on purpose. Maybe, I'm sure you guys have seen this, but it comes from the patient safety world. This is I like this diagram. It helps a lot of discussion. But think about where we are in healthcare. Does this not, can I see this? Okay, so here is the boundary of economic failure. Let's say our administrators are so good that we're way away from that boundary, okay? But in healthcare, maybe we're closer to that boundary than we think. But boundary of unacceptable workload is on the bottom, and on the left side is the boundary of acceptable performance, okay? Now, we have that S, that big circle on the bottom left. That's unsafe because it's so big, right? So we're propagating within this system. We're coming close to our functional performance limits, and we may not even know it, right? And highly reliable organizations have figured out how to get right on the edge of that and have a nice tight circle so that they know they were operating like a fine-tuned machine. They're in right on the border because that's how they maximize efficiency, but they're not exceeding their performance limitations. So that's where we are in healthcare. And sometimes that circle is really too big. So we get to phenomenon such as drift to failure. We're teetering on that level of unsafe boundary, and things like in the EHR, usability issues, communication at the wrong time in the patient continuum and the workflow of the patient, things like that may drift us to an unsafe situation where we actually have a patient event because of the EHR, right? So that's what we got to kind of consider. And knowing when to abort, that can be literal in surgery. If you have several things stacking up, knowing when to discontinue that procedure and abort. It can be a process-related issue. It can be an intervention. Like, no, I think we're too complex in this area. We need to allow a little flexibility. So that's kind of a conceptual thing. Zero complacency, though, that starts to get into safety too, and systems thinking. Like, rather than a metric that says, we're at 1% error now still, even though we switched to EHR, we went from 10% to 1%, but we're still at 1% error. And you think about the number of cases that come through this hospital, that's massive, and you're just like, oh my God, we're screwed forever. If you kind of flip that and say, you know what, now we're 99% effective, but we're not done. I mean, we got 1% left to go. We can put these things into practice. How do we get to that 100%? I mean, it's kind of more of a motivation, or philosophical, sociological thing, but it might improve our culture of safety. And that goes to the leading indicators. All right, so is sort of an iconic approach to investigation that we think about. If we have a device as the center of an investigation, it's a part of a big system, as I mentioned. We've got the user, we've got the hospital, the environment that the device is in. This could be an interoperable device that's talking to the EHR. But we see kind of where the EHR and the IT systems live. And also connected to the user, realizing that nobody's perfect. That user could try to be razor focused. I was trying to be razor focused on our presentation earlier today, but I was just in the back of my mind wondering when our timekeeper was going to notice that our timesheets were stolen. He did it. So you can be distracted, right, easily. So many things are going on in the world that our users aren't perfect, so we have to recognize that. Same thing on the patient interfaces. We have the patient as the center of a device of an investigation. All right, we have the EHR is indirectly attached to that patient through the clinicians, the devices, the environments, and this kind of iconic approach allows you to start really drilling down, asking questions on each one of these areas, and limit the hyper-focus on one particular one to help improve later the recommendations. So with regard to EHR, health IT, what do we want to investigate? Everything. I mean, the whole system, ideally, but because like we talked about before, there's different computers have the different audit logs, and you have to have like that comprehensive approach to look at the entire system to really tell the story, and that is a dubious task. So what we encourage and like to do is work with the implementation specialists and the users of the EHR to figure out where things lie before diving in and hyper-focusing on one particular area and coming to conclusions on that area. So that's just kind of a caution. There's various algorithms of reporting. This is something we put out on how to implement health IT safety into hospitals. And you can walk through that system when you know that you've had an event. So, for example, is it health IT related? Yes or no, you follow that path. If it's not, can health IT improve that situation? I mean, so that's another thing to think about is how do we get to that 100%? Can we put in a metric to improve that error with our health IT, with our EHRs? Okay, so I kind of talked about that already. One thing that's very important to consider, let me just jump, well, that's okay, I'll talk about it here, is that this is multidisciplinary, multi-collaborative effort. When we have an event, we talk about this on the device side or the EHR side, it's often advantageous to have a go team, somebody that knows how to investigate an adverse event, led by like risk or legal or somebody, but involve clinicians, involve IT, involve biomedical engineers, because folks are attacking it from different perspectives, and that's a good way to collect all that data up front. And then you have it as fact. People's minds drift, their perceptions, their memories of the event drift, and what they think is the truth is in fact something totally different, as you might observe from a camera in the OR, something like that. So capturing that data right away is so important. So have that immediate action plan, and then figure out how to report this event and how to fix it. And then consider, we recommend considering a common taxonomy. I mean, I don't know how we're going to agree on like what the taxonomy is for health IT, and there's so many, but ARC has a good common format. I mean, that's what we've used for some of our efforts. There's also others though, I mean, plenty. Hazard Manager, again, that was like a beta program. We've used that to divvy up some of the contributing factors from that one data set I showed you of 332. We've got our device taxonomy that I think could be borrowed into the EHR world as well. So there's a lot but the point is and this is true for any kind of database. I mean, it has to be organized up front with the intent of, okay, thank you, 5 minutes. The question also needs to be answered, what are we going to do with that data on the back end? I mean, we're dumping in millions of reports into PSOs and our internal databases and all that stuff, but what are we going to do with all this stuff? The answer might be machine learning, AI, all that, to kind of funnel it back in to our clinical decision support tools, et cetera, on the front end. So that is a dream, but I think a vision. Getting there is the big question, right? Okay, so again, just to reiterate, because this is, I think, an important issue. Safety 1 is old school. That safety is defined as the absence of accidents or incidents where few things go wrong as possible, and things go wrong because of identifiable failures, malfunctions of components in the system. We're able to figure out why they're going wrong. Humans are the cause of failure. Human error, human error, human error. And you do investigations to find causation, and then the management basically responds when something bad happens. Something happens, we go investigate why that happened. All right, something bad happened over here next, go investigate that. Well, we've all played whack-a-mole, right? There's always something happening, going on. So kind of moving forward, the thing is, like I said, human performance practically always goes right, so some of the lessons learned on investigating positive events could be translated over to the things that go wrong. Also, it opens up a whole new area of resilience and adaptability. I mentioned, drift to failure, those kinds of things. But the resilience thing, recognizing that we're all playing a big game of whack-a-mole, and having the prowess to go after each one of these as they come up and really put them down. So we succeed under these conditions. We're resilient, we're adaptive. It's our responsibility to make it that way as humans, and we investigate why these things go right and try to translate it over. Excuse me. So it's here to stay. We all know this, right? There's so much momentum into health IT and EHRs. Even a trim tabber on the back of a big boat fighting for 50 years is not going to move the momentum of that boat. We're there, and there's a lot of positive benefits of EHR and health IT, and the vision, I think, is still sound from what it was 20 years ago. So there are things on the implementation side. This is just a schematic of a certification program through the ONC, and maybe our friend in the ONC might be able to help us understand this a little bit more. But and also, I know Dr. Siddig has worked on the SAFER guides, the implementation strategies on how to learn from our mistakes or learn from the things that work well and put them on the front end on the implementation side. So I recommend checking out the SAFER guides as well. So, and this is just kind of like a thought. We're close. This National Patient Safety Goal from the Joint Commission was on clinical alarms. This is my little plug on alert fatigue. We were tasked as a healthcare industry to manage clinical alarms, to go through a methodological approach to identify critical alarms, medium, low priority alarms in each area of each service line, essentially, and how to communicate those back and deal with them effectively. So that was a 3-year effort with very specific goals. We could be there with EHR alerts and clinical decision support. I don't know if it's a Joint Commission thing or what, but to really come up with the methodology and taxonomy to deal with the alert fatigue. There's studies out there now, regarding removing a set of alerts that are constantly overridden. And then, I'm not going to steal your thunder, James, later, but that's an example of that. So what works well, what doesn't, and then how can we approach that methodically and as a patient safety goal, because ultimately it is. There are all kinds of resources out there. We work closely with a lot of different other nonprofits. HIMSS and EHRA is an example of a resource that you probably know about, but I will point you to, we just put out an opioid management paper with a collaborative effort between the partnership and EHRA, which is how to manage the opioid crisis and contribute to that effort. So obviously healthit.gov, that's the ONC's resource, and our partnership. So I recommend, all the partnership stuff is free. Just go to the website. It's a grant fund, the Gordon and Betty Moore Foundation, so Moore's Law, that's who's funding that work. So that's